Thank you so much, Dr. Sagar. And I take this opportunity to speak on this topic. I think we have enough time, so we can
एक
go.
तो मुझे ये 2 बजे से बीच में अगर कुछ हो
Yeah, please go ahead. We have time. We are there till 11:25.
Yeah. So what is important, what we have been struggling, I will tell you my personal experience. I've always felt that the refractive outcome, the predictability of LASIK, we have not been able to replicate in cataract surgery. So slowly we have to go to that direction. And what you see here is the refractive outcome prediction has become much better, and again we are able to repeat it much more frequently, but still we have some way to go. Now sources of error, what we can have is either a biometry error, astigmatism planning error. Manual marking was a big handicap till we have the digital marker, cyclorotation while doing the marking. Surgical induced astigmatism, it is all personalized. If all of us have to get it calculated for our own surgeries. Size of capsular axis is again an important part of the planning, and position of the IOL. So it's few years back when we first had this machine, and my first impression was that it is such a huge cost just for the marking. And that time the impression was that it is mainly for toric IOL marking. But then there was changes in the impression when we got to know about the machine much more. And what is there is probably the keratometry is more reliable, because the number of reference points taken on the cornea for the recording is much more than the other biometry machines. So if there is a difference in keratometry of optical biometer and Varion, then many times we have to lean towards Varion findings in those cases. Predictability of post-op refraction is much better. Most of the optical biometers give you the spherical equivalent, but in digital markers, what you get is the breakup of the sphere and cylinder. So that is again very important thing when we are planning to give a good refractive outcome of the patient. And so what we got to know from surgeons who were using digital markers, they told that they have been implanting even T2 lenses after they got the digital marker with them. So that changed my impression to some extent. And if you see the utility, sorry. It is first we take the preoperatively, we take the image of the eye, then plan the surgery, and the same thing we use in our operating theater. So what we do first is the data capture, and what they do in that is acquisition of a high resolution color reference image of the eye. That the machine determines the radius, the corneal curvature of the steep and flat axis, limbus position and diameter of the cornea, pupillary position and diameter, and the corneal reflex position. So the patient information is saved, and this is the pre-op image what we take. Now comes the planning. So when we plan, we select the intraocular lens, and various IOL formulas are available in the machine. So all the formulas we can test. Then astigmatism management, toric IOL implantation, even planning related to clear corneal relaxing incisions is done, and the plan is exported. Now, just for reference, I've taken my findings in this, and what you see, the incision site is marked, the IOL formula, and most of the times it takes the Barrett formula and expected post-op refractive outcome. So in my biometry, if you see, if I use a non-toric IOL, my post-op refraction expected is plus 0.48 sphere and minus 0.5 cylinder. So but the same thing when we go for a toric lens, so it is coming to a T3, and it exactly tells the spherical and the cylindrical component. And in my post-op refraction with toric IOL, it is coming to 0.1 sphere with 0.1 cylinder. So that gives us much more confidence when we are implanting a toric IOL. And when in the other biometers, when we are getting the spherical component, so many times the sphere and cylinder may can negate themselves, and we get a small spherical spherical component of that, and which may not be very accurate. Now, same thing when you do with other machines, what you are getting here is the spherical component in both the non-toric and toric lens. So we are not very clear about that. And when you see with the IOL master, again, in IOL master, what we are getting is the post-op refraction is the spherical equivalent of the power. So that is one of the added advantage. And while planning, this is how the machine, the interface in the OT is there. And when we are planning, you need to have an assistant which will mark your sitting position, whether we are sitting in the temporal, and based on the pre-op planning. So first, what you see is the sitting position is marked, the capsular axis is marked to 5.5 millimeter, and then we start the surgery. First, the patient registration is important, and this is another advantage. Suppose many times in our fellowship days, we used to block the wrong eye, or sometimes in OT, when the OT attendants are not very careful, they clean the wrong eye. As soon as the variant image is compared, you will get an alert that this is not matching with the pre-op image. So that error also gets minimized. And what you see here is a good 5.5 capsular axis. And this is being monitored by your assistant, who keeps on changing, or it is also available on the foot switch of the microscope most of the times. And once you implant the IOL, the centration can also be assessed quite well. If the two Purkinje's images are coming in the central circle, then it is well centered. And the accurate alignment of the toric IOL. What you see, in this patient, the axis of placement was 170 degree, and finally the centration. So this is how the machine operates. Now, I'll show just two short videos of how we see in the microscope. And what you see here is all the side ports. Main port has been identified. The capsular axis of 5.5 millimeter is done. The main port incision mark that corresponds with the digital marker. And once the IOL is implanted, the accurate alignment using the digital marker. And another thing, if you save a lot of time in pre-op marking when we used to do it with the manual markers. In this, no pre-op marking is required. In first few cases, just to be double sure, we can do the pre-op marking with the pen and see whether it is matching with the Varion or not. And my first toric multifocal, I started implanting only after we got the digital marker, because I never got the confidence with the manual marking, and we will be able to deliver with a high demanding patient who is opting for a toric multifocal IOL. So once it is done, again, the same thing is done. And in this, since it is a multifocal IOL, at the end, the centration check is also important and is must for these cases when you are using a digital marker. So another thing what we faced, and this Dr. Sagar is also aware about this patient, is the post-LASIK biometry. This is one thing, one patient, we had a post-LASIK patient, and she was so demanding that she wanted a zero power, even the post-LASIK. And the dilemma was that in Aladdin, it was coming to plus 18, in Varion, it was coming to plus 20, and in IOL Master, it was coming to plus 16. But once after internal discussion, Dr. Sagar suggested that we use the Shama's formula in the Aladdin, and that is what I used and got a 0 power for this patient. So this, I would say, was the limitation of the digital marker system. Post-op assessment, we can, again, after few cases, we can do a constant optimization for ourselves and the surgical induced astigmatism. Outcome analysis, toric IOL post-op day 1 getting 6.6 is quite frequent nowadays. The number of toric conversions have increased because of the increased confidence in the system. You can also use mild astigmatism and T2 models. Toric multifocal has increased. Post-LASIK, again, is a still to be seen. I'm not very confident with that. And of all that we have been using for almost 3 years now, and most of them except 3 or 4 is spot on. Thank you so much.